Some history between us and Dr. Dan Lowe. Several years ago, I connected with Dr. Lowe in Seattle. We went to the Museum of Flight. We did a presentation together, and I looked over at him and I said, oh my gosh, I did not know about behavioral markers. I did not know about my own context as much as Dr. Lowe did. So we learned a lot from each other. I learned a lot from taking a look at the patient journey, from following the patient journey with Dr. Dan Lowe to see how awesome they're bringing lessons from fighter aviation, lean, the Toyota production system, human factors into healthcare. So Dr. Dan Lowe, I want to start with your new company, mainly on what problem are you trying to solve and how are you solving it with AdaptX?
Great. Well, thank you. And thank you, Brian and Mark, for inviting me to the show. It's a pleasure to be here. Great recap of how we met. 5 or 6 years ago, I started a company called AdaptX. The problem we're trying to solve was, I've been in America now practicing as a physician for 12 years. And when I first arrived here in 2010, most hospitals were still on a paper record. So every time you gave a drug, every time you charted the blood pressure, every time you did anything, you put it on a piece of paper. So you can't do anything with that. I mean, you have a record, but that's it. Over the next 4 years, by 2014, the whole country had now transitioned to digital healthcare records. The operating room is the last place to get it. So, so Brian, you've been inside the operating room. You see it's you call it a VUCA environment, which is absolutely accurate. It's high paced. So while you're doing this, how can you possibly be typing and using a mouse and charting at the same time? And so the operating room was the last kind of bastion that kept paper, because it was faster to chart with a pencil than it was to do it with a computer. But they figured out the technology. They've got all that data now. So for the first time now, we have 100% digitization of healthcare records. The problem now is how do we use that data? We have a wealth of data, but a poverty of information, right? So the data's there, it's stored in a warehouse, but I, as a clinician, can only access it one patient at a time. So I wanted to solve that problem. How do I know if we're doing better or worse? How do I know if we change a drug from drug A to drug B, that's actually adding value to patients? How do I know if we change workflows or team structure? Or, how do I know that's more efficient? How do I know that that's better for the patient? How do we know if we're adding value to the system or taking value out of the system? So AdaptX was set up to solve that problem, that kind of access to the data, so you can basically manage all these unmanaged processes right now.
So it's all about decision-making in healthcare or in the surgical or operating room, right?
Not just the operating room. We started in the operating room. We're now live in pretty much every area of healthcare you can think of, from the ICU to the emergency room to urgent care to clinic. This is all, you'll like this, it's all flow. It's all a flow. If you think of it as a flow problem, it's all, how do you optimize flow through these systems that you get the best optimal outcome, and you have less and less choices of which paths you go down, so you optimize the outcome that you're after. And that's where our worlds intersect, I think.
Absolutely. Now, looking at your webpage here, you have strategize, plan, execute, monitor, evaluate, and adapt, right? So,
yes.
To me, that's John Boyd's OODA loop in a nutshell. And you're trying to improve decision making, decision support tools to help improve decision making. And I think you're using big data and a little bit of AI to do that as well. And like you just said, there's a wealth of information in there, wealth of data, but a poverty of information. Is that your phrase?
A lack of information. Yeah, that's what we don't have enough of. And it almost sounds like an oxymoron, right? How can you be starving for information when you're floating in a sea of data? How can that be?
Yeah.
But that's exactly where healthcare is right now.
Wow. So let's go back in your journey and connect what you're doing with AdaptX back to where you learned something that I learned in the cockpit as well. And that was I think you were in a helicopter emergency medical services program in the UK. Mm-hmm. Is that correct?
Yes, correct. Yeah. So I had the privilege of working for a HEMS team, a helicopter emergency service, just before I left the UK. So that's 2008 to 2010. And it opened my eyes to what was possible. And the real thing, I mean, I learned some really cool pre-hospital emergency medicine for sure. But the thing I really learned in that 2 years is application of human factors. How can it be that this 3-man HEMS team can do something in a muddy field in the rain faster, more efficiently, more reliably than I could in a well-lit OR with 9 people? How could that be? And it was actually our base captain who taught us. His name was Simon. He was an ex-military pilot who was also, he was the base captain. He flew the helicopter, and he taught us human factors. From 20 years of military aviation experience, he distilled it into our medical team. It was a real honor and privilege to learn from someone like that. And so after that experience, when I came to America, I was tasked to bring human factors into healthcare by the hospital I was working at University of Washington and Seattle Children's, and I started teaching these human factor concepts and how to operationalize them.
So, what were some of the lessons that Simon taught you in the cockpit?
Well,
what were they?
It's a whole framework. It starts with, well, first of all, I didn't have the language, right? I didn't have that matrix. Human factors, situational awareness, knowing what's going on around you, decision making, communication, teamwork, leadership. That they're the domains, and you both know that. But what I didn't realize, and maybe I had at best a passing familiarity of what those terms might mean. He broke it down to a behavior matrix. Let's take situational awareness. You can do a behavior that accentuates your situational awareness, or you can not do a behavior and have poor situational awareness. One of those things is, do you attend a briefing, right? Or do you brief before a mission? If you brief, your situational awareness is going to be a bit high. Every morning we had a brief. He'll talk about the weather. He'll talk about no-fly zones. He'll look at the NOTAM report. Like, what's out there that's going to kill you today? Or your crew. And if you know where those landmines are, how about we not step into them, right? So it starts with that. And then after the mission, you debrief again. So again, that builds situational awareness for your next mission. You do a hot debrief as soon as you land and drop off your patient, and everything's tucked away before you strip out your flight suit. You let's do a hot debrief. Take 5 minutes. So simple things like that. Teamwork. There's a behavioral matrix for that. I didn't know. I just thought, you just kind of pick that up as you go along. But you can break it down to 12 behaviors. One behavior is, for good teamwork or good leadership, is actively solicits information from the crew. Did you do that?
And that builds psychological safety, right?
Yeah. If you did it, that's a good leadership behavior. If you don't do it, then that's a bad leadership behavior. And he made it binary. And it was like, it opened my eyes. It's like, you don't have to muddle your way through 20 years of being a physician to learn this. These are skills that can be taught, they can be assessed, they can be reviewed, and and it's objective. It's not fuzzy. We often think in healthcare, the technical skills is what you learn at medical school, and the technical skills, what button to push on the ventilator, what lever to push on the machine, technical skills. Okay. Yeah, they are important, but the things that kill patients and cause patient harm are non-technical skills. We've known that for 15 years, but yet we've failed to train systematically in non-technical skills or human factors. I use those terms interchangeably.
Right. Soft skills and human factors, team science, crew resource management. We all, it depends the group we're talking to. So let me, there's a couple things that you told me a few years ago, and I think a lot of people in your industry are familiar with the checklist manifesto and your experience. Can you talk about your experience in learning what a checklist does when you were working with Simon?
Yeah. So he taught us checklists. I learned checklist 101. Before I worked with him, I didn't know that these things had a name. There's a challenge response checklist. There's a read do checklist. Now, you're both smiling. You go, well, of course.
Mm-hmm.
How could you not know that, right? But in healthcare, when Atul Gawande first wrote the checklist manifesto, or better, or complications was his first book, and he was Atul Gawande was the champion for introducing checklists, right? The concept was right, the execution and how he operationalized it. If we had a do-over, I think we would do it differently. You got to teach the building blocks, like right from the basics. When I first arrived at Seattle Children's, we had the WHO, the World Health Organization checklist, because we were told that if you put this checklist on the wall in your operating room, you'll save X thousand lives. Yeah, but that's not that, like, and it was this huge, it was a manifesto. It was a document. It was really wordy. One of the things, the former Surgeon-in-Chief, Dr. Solomon, at the time, he brought in some Boeing pilot trainers and said, come and look at how we do our checklist in the operating room and give us your feedback. After they saw it 3 times, they just walked out. They said, we've seen enough. You guys don't know how to use a checklist. We literally had one person just going, well, we're chopping off the right leg, or, the right kidney, and we don't need antibiotics. The rest of that, no, we're good. Let's go. That was it. My job, because I had some expertise in this, was to help the system teach them, how do we do it? How do we convert that, 2,000 word document into a 12-word document? How do we make it into a challenge response checklist? And this concept of having the junior member of the team issue the challenge and senior members of the team, or different hierarchies, be responsible for the response. This was important. Having the quietest member of the team lead the checklist activates that team member, gives them situational leadership for that 30 seconds. They're used to speaking up. So now if something happens an hour later, they're used to speaking up. They're used to being activated. They're used to being heard and being able to speak. So it was a very deliberate kind of flattening of the hierarchy, just like we learned in CRM and aviation. Too steep a cockpit gradient is very, very dangerous. Again, too flat is also dangerous. That's another problem. But in healthcare, we had a very, very steep OR hierarchy, and we've had some pretty serious across the world, pretty serious complications. Catastrophic complications, like cutting out the wrong kidney, even when there was 2 people in the room who knew that was happening. They didn't have a voice to speak up. They didn't have there was no structure in that team that allowed them to have that voice, even though they could see something bad was happening.
So one of the things I observed when I got to spend the day with you in the Seattle Children's Hospital is, I believe you had some younger doctors. What do you call interns?
Residents or fellows? Yeah,
residents. Yeah. So, and I do remember this. Me not being too smart on what's going on around me in that type of environment. We didn't have our masks on. The type of environment we were in. Yeah. And then a nurse stopped by to say, "Hey, we need to put our masks on." And then I believe one of the residents was having troubles getting an IV into a patient. Mm-hmm. And I just remember how the residents were able to challenge you on some of the procedures. And here I am looking at a hierarchy inside of an organization. I know the hierarchy, and they're able to challenge you and push you around a little bit and speak up. And I think that is something that you create through human factors training, is you create that environment where anybody can speak up. Yeah. And then the transition from anesthesiology, from the room that the patient's prepped in to the operating room, is pretty powerful, because there's a handoff there, right? There's communication happening. There's one team going to another team. And I also saw this, and that was the doctor that was going to do the procedure came in and started asking everybody why they're there, which included me, right?
Yeah. The first thing. Right. The first thing you have to do with a new team is you have to activate the team. And so that was built into our checklist at the time. The first thing is team introductions. You have to say your name and your role. And if you just say that, you're now activated. Your chance of saying, even as the observer, Brian, you could have said, hey, is that light supposed to be flashing? Like, your chance of saying that is so much higher if you've already spoken up in front of 10 people.
Yeah. And I just say everything I saw that day, it reminded me of life in the cockpit from the time we start planning to the debrief, right? How we get better. And then we went on a tour after that. And he showed me some of the artifacts on the wall. A lot of them were lean artifacts, which we could dive into in a second. But one of the most powerful artifacts you had up on the wall, and this is right before the morning, I don't know what you call it, a daily brief or...
Yeah, we have a daily huddle or stand-up. Huddle.
But on the board there, you had SBAR. Remember, situation, background. I forgot what the A and R are.
Assessment, recommendation. Right.
Right. Just a basic communication approach, right? So it sounds, kind of funny that these adults who are well trained have to learn how to talk to each other and have these reminders on the board of ways to communicate, right? Can you talk to us about the adoption of that inside of healthcare and how that's kind of changed? Yeah.
Yeah, I think I think having tools and a structure to communication. You're right. I mean, you got these highly trained adults who've been to a lot of school, right, and highly functional, very skilled, and yet you have to give them a communication tool. And the reason for that is by standardizing the communication, the format of it, the reliability goes up. So you both know that in every industry, the more you standardize, the less variation there is. You also know that the less variation there is in any industry, the quality goes up. So we learned that. I mean, you don't have to look very far. We're in Seattle. Go to Starbucks. They taught a gajillion people how to order coffee. If you order coffee in the wrong way, so my drink is a double tall latte. When I arrived in America, I didn't know what that was called. I said, I want a kind of that one, the 12-ounce one, and I want 2 shots, and I want that kind of foamy milk thing. And they'll go, oh, you want a double tall latte? And they'd correct you gently. And the next week I went in, I said, yeah, I'd like a latte with 2 shots. And they'd go, oh, you'd like a double tall latte. They would repeat it. And what they're doing is the baristas are trained to teach the customer how to communicate. So that, and if you make that communication crisp, not only is the orders come through faster, they're more reliable. Your chance of making a wrong drink is lower, so you waste less resources and you don't make the line, and they make money. That's for ordering coffee. You look at how we order drugs. If I ask a resident, hey, Dr. So-and-so, can you push 20 milligrams of, propofol? Before we did this training, I'd get this, Well, did you hear me? Did you do a readback? Did you verify it? Did you tell me it's done? Now, if I say, hey, Brian, can you push 20 milligrams of propofol? You'd put your hand on the syringe. You go, Dan, you wanted 20 milligrams of propofol? Yeah, copy that, give that. And they would ask for a confirmation, and then they would give it. And then they'll say 20 milligrams of propofol just hit the line. Thank you. They would actually do the readback as well. We had to teach them that. Simon taught me that in aviation. He didn't always fly rotary wings. He used to fly fixed wings. And he said, hey, if you look at a fixed wing aircraft and you're shutting down an engine, if there's a fire on engine 1, a well-trained crew will say fire on engine 1. The co-pilot might put their finger on the extinguisher to shut off engine 1. And he'll say shutting off engine 1, but won't hit the button until the pilot gives a secondary confirmation. Yeah, go for it. That's the right button, right? Like he said, a well-trained crew will take that extra quarter of a second. Well, we should be applying the same degree of finesse to how we communicate in healthcare. And SBAR, the commonest thing I get called for at 3 a.m. if I'm asleep and I'm on call is the ICU resident is calling me because there's something bad happening. And usually the conversation used to be, I'm sorry to wake you up. Hey, my name is so-and-so. I've got this, and they'll start this story. I don't want that. You don't have to be polite to me. Give me the SBAR. Situation. I got a 6-year-old who looks really sick. I need you at the bedside. Okay, start with that. Okay, now my shoes are on and I'm walking, right? And we teach them, give me the situation. I've got a 6-year-old who's having a severe asthma attack background. We've given 20 doses of albuterol. It's assessment. It's not responding. Recommendation. I need you here to do a crash intubation. That's great. So that's a nice crisp communication. We even teach them, if you want it even crispier, start with the recommendation. It's a military thing. Bottom line up front. Give me the recommendation. I need you at bedside by bed, on floor 5, bed space 27 right now. Start with there, and then give me the S bar after that, right? So but these are skills we had to teach.
Yeah. So, Doc Lowe, that is a very solid approach for a chaotic environment where we act, sense, respond. I need you to do this, and I'm going to tell you why, and then we'll have a conversation about it.
Right.
And that's opposed to the passive aggressive. Let's have let me kind of kick around what I really think, and maybe I'll get to the point later on. That doesn't work. So there's nothing wrong with that type of heavy command and control, and you can train your subordinates and the people around you to do this. It's called distributed leadership, right? We want people to lead all the time, and I think that's a great example of what most corporations don't understand is you can incorporate these into your day-to-day work environment. I do want to talk a little bit about something else, and that is your experience with the Toyota production system. I believe you went over to Japan. You spent some time with TPS, right? Because every healthcare organization had to go lean. Can you walk us through that?
Yeah, it was one of the most. It was a 2-week. It's the highest growth period I've ever had in my life. It was 2 weeks in Japan. I did a lean. It was training for lean leadership. My hospital sent me over there. My previous, my chair at the time, my chief, was Dr. Lynn Martin, and he said, you're going to Japan for 2 weeks. And it was over my 40th birthday. I didn't really want to go. It's like I had this other trip planned. And he goes, no, you're going. And I said, well, really? I have to go to Japan to learn this? He goes, why? And after the third conversation, he kind of like shook me by the shoulder, said, you are just going to go, you're going to learn, and it's going to blow your mind. You're going to come back. And it all came true. So what I learned in Japan, so it was a lean, training trip. We went to see, I lost count, a dozen different factories who had at different stages of their lean journey. The most young factory who'd been doing lean had been doing it for 15 years. The most mature had been doing it for over 100 years. So we ended up at Toyota. And as you see that maturity, and it's agnostic of industry. We went to a cookie factory, a furniture making factory, a door making factory, and eventually a car making factory. But once you learn how to read a production line, read the floor, you can see these concepts. And so, simple things. Someone who's got medium mature. It was a high-end furniture factory. I remember standing, watching, and this concept of going to Gemba, they say, go see the work. Don't take photographs. Go see it. Go watch it. Just observe. You can draw. But really look at it. Don't take videos on your phone. Look at it. Really see what's going on. I stood there for 20 minutes watching one person work. His job was to take the chair and put the primer on the chair before he passed it off to the painter who actually put the nice finishing coat, but he primed the chair. Before he primed the chair, he made sure that the legs were square, because there's no point in priming a chair with wonky if you have to go to cut it again. And so he would do this work, and I'd say, how? And 5 chairs went by, none of them had any defects. I said, why do you bother checking? He goes, well, once every 2 weeks, there'll be a chair that's a bit wobbly and it's not quite squared. And then some of my colleagues, American colleagues, said, oh, so do you have an e-feedback system that you fill out a form to tell someone there's a defect? And the Japanese furniture maker said, why would I do that? Why would I fill out this corporate form to say there's a defect? No, I'm going to go and find my buddy Brian who gave me that chair and say, hey, this one didn't work. And he'd go, oh, you're right. And he would fix it, right? So this concept, I remember the Japanese workers like, wow, you do that in a hospital? You'd send a series of letters and emails that goes right up to the director level and then come back down rather than have a conversation. And so that was enlightening. How they how they inspected, how they made autonomous teams. I remember going to a door factory, had 2 assembly lines. They had production board visibility, just like we have in AdaptX now. What is your output? Today we're supposed to make 65 doors or whatever it was, and it's now 11 o'clock. Are you on target? Are you off target? We were there about 2 o'clock. They had 3 hours left of the working day. One line was about going a little bit slower. Both sets of workers could see the other line was slower. They diverted 2 workers to the other line to help them. They didn't need a manager to do it. They were autonomous flow. If you create that visibility so people can see what is happening, and if you create that culture that if I can see what's happening, I'm empowered to help, I'm going to help. They finished the day when both lines finished on time. So great. And we need more of that. And then you go to all the way through to Toyota. And I remember standing, when you go to the Toyota factory, you're standing at the top and you're walking over there. And I remember observing, there's 2 stories. One was that one guy was trying to put a wing mirror on, and after about 60 seconds, it didn't go on. He pulled the andon cord. The whole factory stopped. And and a light starts flashing, and it starts to play this kind of like tune, and a supervisor comes down and he's looking at the part. He helps him do it, and then the line starts again. But he's like, they are aggressively going after defects in flow. And I said, well, what happens now? He goes, well, that supervisor is now going to log that and say that happened, and they know how many times it happened, and they're going to go back to root cause and go, hey, let's not have that delay. A frontline worker stopped the entire factory floor for 4 minutes.
Yeah.
I've not seen that in healthcare, right? It's like when something's wrong, we pass.
So why is that? What? So you have a lot of egos, and I'm saying this in a kind way. You know, these are well-trained people that spend years in a university studying. They have egos, right? So how do you get that type of personality or persona to pick up these concepts of human factors and these simple concepts that you're talking about now? How do you do it, or how hard is it to do in your environment?
I think it's challenging to do because it requires we have to reframe our mindsets. As physicians, if you look at the last, 100 years of physician training, it's all we're trained to value our autonomy over pretty much everything else to a fault. Our ability to do what you're trying to teach industry, to work as a team, trying to achieve a common goal, acknowledging that I might not have all the answers, I might be wrong. Acknowledging that, hey, if we decide to do something in a standard way, clinical standard work, I might not agree with it. I might have an opinion that it's something else is better, but being able to go with the flow, so well, let's try it, and let's measure it, and having the faith that the system will say, hey, in 6 days, 6 weeks, if this is not working, we're going to tweak it again. We're going to modify the SOP, the clinical standard work. But so it's a chicken and egg situation. You have to create the system where people don't think their autonomy has been taken away. So you came to see me at Bellevue. We have probably the most robust clinical standard work. If you brought your kid in to have a tonsillectomy with me, they'd get exactly the same drug combination as if they worked with Jen or my partner Tim or with Lynn. To the milligram, it's dialed in. But because we all work together, and what we've done with AdaptX now is when we all work together, we measure the result of our outcome. And so we tie in, if you do this piece of work, you get this outcome. Do we like this outcome? Do you want to move it up or down? If we want to move it up or down, what tweaks should we make? We used to make tweaks every 3 or 4 years. We now make tweaks every 3 or 4 months. Our ability to learn, that kind of like that learning cycle, where I showed you said, where is just so much faster because we're monitoring and we're evaluating, and then internal, like, what does that mean? And then you can adapt and adapt and adapt. So we've been able to learn so much faster. And I believe we're on a point of a revolution, right? We're on a point, if you, we were just talking about this a couple of weeks ago. If you wind back the clock to the 1980s, the big thing we did in medicine was that we started monitoring patients, little pulse oximeters, blood pressure cuffs. Before, in the 70s, you'd look at them and go, well, what color are your eyes? And are your lips pink or blue? And honestly, when the pulse oximeter came out, people say, I don't need that. I can see, if he's blue, that's bad. And if he's pink, it's good. I mean, that's where we were in the 70s. In the 80s, that technology enabled you to monitor your patient. And if you can measure an oxygen saturation, which now you think, gosh, everybody has, you can buy one for $20 off Amazon and put it on your finger. If you can monitor that oxygen level, you can manage that, right? You don't have to wait till it drops till you're visibly blue. I mean, if you're visibly blue, you're one step away from being visibly dead. So you don't have to wait that late. So this concept of the ability to measure what matters and to do it rapidly, that transformed healthcare in the early 80s as patient monitoring got better. The next revolution that happened was patient safety. So they took all the things that shouldn't happen, death, wrong-sided surgery, giving the wrong drug, whatever it was. They started documenting and collecting how often does that mistake happen? How often does that happen? And they started rigorously going after those errors. And so design systems to stop those bad things happening. Where are we now? Now we're in this third revolution where we have data that only 10 years ago you could only dream about having all digitized. And we're just starting to scratch at the surface of, oh my gosh, if I change that drug by 10%, drop it or increase the dose by 10, what does that do to my outcomes? And we're now able to understand it at a level that's not people telling stories in the coffee room. Is you can see it on a chart. And again, once you can measure something, you can manage something. So we have all this, just like in the 80s, you had all this unmanaged low oxygen levels. Like they must have been hypoxic patients that were unmanaged. You put a pulse oximeter onto those patients. Now it's being managed. Now their outcomes get better. We're seeing the same thing across large groups of patients now. We have the ability to do that. So it's a very exciting time to be practicing medicine.
So now you're blending big data with the human factor side. That's kind of how I see this working out in the future. Is you have to work you have the technical thing now. You understand that. We understand we're getting more information. Is this what you're aiming for? Is to blend all the worlds that you've been in touch with, the aviation world, with the lean world, with the medical world, and this big data world? Are these merging together? Is that
I think so. I think, as I was talking to one of the trainees this morning. I said, and he's a fellow and he's starting his career. I said, I wish I was you. You are entering a landscape that has never existed before. You're entering a landscape into independent practice where you have this data at your fingertips. What took me 20 years to learn, you could learn in 2 minutes. So this concept of digital aging, you don't have to have done that procedure 2,000 times to know the recipe that gets you the outcome that I get. You can learn that in 2 minutes. And the example he gave, he said, I just looked across the 72 anesthesiologists that we work with who do this procedure, and I found the best person that I want to copy. I said, that's great. They've on average been practicing 10 to 15 years. That's 800 years of experience. And you went straight to that person does that the best. I'm going to copy them. You just became Yoda. You just aged 800 years. I mean, that's how long it would take you to figure that out. And so, and this is going to happen faster and faster. I believe we're about to accelerate what we can learn. There's in medicine and healthcare, not just like, working faster, working more efficiently, but like what therapies work better, what are the nuances, and we're finally in a position to kind of figure that out. You're right, Brian. Like there's the technology piece. There's I can show you this is a better way to do it. Where's the human factors piece? If I know that there's a better way to do it, what stops me as a human being from doing the better thing? Ego, pride. How can And so how can we shape our teams not to take it personally? Hey, it's not like, oh, my outcome isn't as good as the best person in the group. I'm going to be really offended and I'm going to defend my way of doing it to the death and come up with clever arguments of why I shouldn't do that. How do we go from that to, hey, Brian, Mark, what you're doing is better. You're getting a better outcome. Can you show me how you do that? Can you coach me? I'm going to start doing that. I'm going to come back to you 2 weeks later. I'm going to share my outcomes. If my outcomes aren't matching yours, can you give me another session? How do we go? How do we go from there to there? So, and how do we do that at scale?
So, staying in that theme, one of the big lessons that I'm taking away is that this is universally applicable. And when you're dealing with those types of personalities that you just described, I imagine that at some point you've run into someone being extremely resistant or extremely dismissive. And I wonder if you have a anecdote about a conversion to seeing the light, to adopting this.
Yeah.
And somebody that didn't adopt it and it led to something less than optimal, something disastrous.
I have a couple of stories I can share around that. The first is, one of the projects that's been happening at Seattle Children's, led by Dr. Liz Hansen, she's one of my colleagues, is she's figured out how to reduce the carbon emissions from the hospital, from the operating rooms, by about 90%. So the fumes that we give off from the anesthesia gases are incredibly toxic, like 2,000 times worse than CO2. So as the operating room, we account for 7 or 8% of the total emissions from the hospital. And she cut that down by almost 90% in a year. The way she did it is she showed the variation in practice, and she showed on a plot, where do you all fall? Some people are high polluters, some people are extremely low polluters, and some people are in the middle. And she showed that variation. And then she made people care. She said, so you know that if you use nitrous oxide at that rate, you know that that's still in the atmosphere 104 years from now. Your great-grandchildren will be breathing that in or having the consequences of your decision with ozone depletion and global warming because of your choice today. What you're doing has 100-year lifespan. So she made people care. And then she measured. Now, there's 1 or 2 people in the group who either don't believe in climate change or just didn't care, and they refused to change their practice. So over this 18-month period, the group has got tighter and tighter. The variation is less and less, and their emissions got lower and lower. If you fast forward now 18 months, fast forward to today, you take the worst, I say the highest polluter today in our group. If you teleported him back in time, he would have been the best person 2 years ago. So sometimes, even though you have folks who don't want to get on the program, I like boating analogies. A rising tide will lift all boats, right? If you move the group, there's something like group magnetism, group momentum. You will drag people, even if they want to be, don't even know they are. You can drag them along. So part of this kind of like evangelism, whenever you're trying to change a system, I had some great advice a few years ago. It's like, there's going to be 10 or 20% early adopters. There's going to be people who go, wow, that's a great idea. Let's do that. There's those champions. Go after them. There's going to be that middle tier, that 40, 50% who go, well, I'm going to go with the flow, right? So, but they'll be influenced by that 10, 20%. And then there's the 10% at the back end who are actively opposing any change. And he said, don't waste your energy there. I mean, listen to them and empathize, but don't make that 10% take 90% of your time. Go after the people, preach to the converted, right? Go after that 20%. And that's where you're going to get your change. Go after your champion.
And then a theme that comes up with us a lot is speed. And it seems that you're able to speed and advance things faster by taking this approach versus the quote unquote old way or the status quo.
Yeah, the speed, speed to value. So AdaptX is all about speed to value. A typical hospital system, a 250, 300 bed hospital has probably spent $350 to $400 million standing up their electronic medical record. The current state is the average doctor, average clinician in those health systems, who can spend $400 million. If you have a question about, I want to manage this process better, I want to make this thing better. First thing is, well, what's your baseline? You need to get some data. And then the second thing is you need to do a small test of change. And if that test of change is good, you measure it. Did that work? Did that not work? If it worked, let's do it some more. But the step one is get that baseline data. The average hospital, it's 6 to 12 months to get that baseline data. So before you even start thinking, how can I tweak the system? You have to wait a year. Okay, Mark, put it on your calendar. Brian, next year, we're going to talk about this, right? So, and then once we talk about that, I'm going to give you some, and then we'll start a thing to make that thing better. How does that feel, right? That's a great way to disengage your workforce. If you put a 6 to 12 month barrier between them, getting access, the ability to use the data that they enter every day.
And as a layman, I suspect that this increases the quality of the care that you're bringing, because oftentimes you're up against time, right? You're up against the clock when it comes to saving someone or helping someone. So I imagine it helps stream.
Yeah. Whenever we try to improve complex systems, as you know, you don't take a unidimensional. We're going to make this measure better. You want to take a family of measures. You want to make this better. You want to make that better. You don't want to make this thing worse. And you certainly don't want to make this thing worse. So you take a family of measures. So whatever intervention you do, you need to take a family of measures and go, am I moving the needle all in the right way? Some can stay neutral. That's okay. But am I moving everything the right way? And now we have the ability to do that.
Hey, Doc, how did you become familiar with complex systems? Just curious.
Well, I think I started with the most complex system there is. The most complex machine I know is you, a human being. So, so my background is I started as a pediatrician and then a neonatologist, and then I started training in anesthesia and critical care, and then later on pre-hospital medicine. Anesthesia is kind of where my heart is. And when we deal with anesthesiology, here's anesthesia 101. The first thing I do is I give you a drug that shuts off your brain. When you shut off your brain, that's your central nervous system. Your central nervous system, your computer controls all these other subsystems, like it tells you to breathe. So now I'm responsible for not only for your brain, but I'm also responsible for your respiratory system. When I shut off your brain, I also shut off inputs to your cardiovascular system, and it does weird stuff, and suddenly you drop your blood pressure by 30%. So now I'm responsible for your central nervous system, your respiratory system, your cardiac system. Your cardiovascular system is intricately intertwined with your breathing system. And so what you do with one affects the other. And so that's only 3 systems. Now we start talking about, well, what other systems are there? Well, there's your neuromuscular system. So, part of anesthesia is you give paralytic drugs. Now you can't move, and then you can't shiver, and you lose thermoregulation. And your renal system is now contingent on how much fluid I give you. And your hepatic system is so now you've got 6 or 7 or 8 systems. And you change one, and they all have knock-on effects to the other thing else. When you do critical care medicine is all about system management of an individual human patient. When you have a disease process, a trauma, let's say I get out of my car, get knocked over by a bike, right? I now have a head injury. I now have to manage the head injury and what's going on to preserve my brain. But I also fell over and he broke my leg and I lost a bunch of blood. Now I've got to manage my cardiovascular. So you can see how a trauma disease can affect multiple systems in a single human being. So my lens into complex systems was learned by looking at, just this one human being at a time. But that mindset, being able to manage complex systems and seeing interrelationships, is very, very applicable to looking at larger systems. It's the same thing. It's the same.
I believe healthcare is described as one of the most complex systems in the world. And
yes.
I can't remember who made that quote. So, okay, we know from our experience, our shared experience with human factors and toilet production system, and now complex adaptive systems. So we understand leadership, teamwork, we understand lean, we understand flow, we understand a little bit about complexity. In healthcare right now, how difficult or how successful have, those that are pushing team steps and things like that, how well are they doing in healthcare to get people to look at their system or their teams and inject things like human factors, the team steps program, lean thinking?
I think it's highly variable. When it's done well, and I am very biased, but the place you visited, I think it does it better than anybody else. It's integrated those two things you just talked about. I think there's, TPS teaches you Toyota production system. You need two things. You need process. You need really good process, and you need to constantly refine that process. You also need really good people. And that's the human factors. And so when you go to Toyota, they give you a lecture. It's like 2 pillars of the roof. To hold up the roof, that's TPS. You need people and process. You take people with the wrong mindset, you give them the great process, the roof falls down. You give great process, you put wrong people in there, roof falls down. You have neither, there's no roof. I mean, so if you talk to folks in healthcare and you say, what bugs you? It boils down to one of those two things, and sometimes both. So I think we have as an industry, we have a long way to go to have robust ways of thinking about systems-based practice, like getting your processes really dialed in. And then, and a lot of that is a chicken egg. You have to have leadership that understands this and builds teams in order to support that work, those cross-links.
Somebody's got to break the cycle, right? Like you say chicken and the egg, like someone's got to step up and break the cycle, right?
Yes, exactly.
So are you still bringing in executives from all over the place to look at what's going on inside of Seattle Children's Hospital?
We were COVID shut that down for a bit, but the folks are still are gradually coming back. We're held up as an example of one of the most efficient surgery centers in the country, and people are still keen to learn about and see our systems. So yeah, those groups are coming back slowly.
So when you and I toured, or when you took me on a tour over there, you pointed out that many folks that come in there look at the artifacts, of lean, the S-bar on the wall and things like that. Mm-hmm. And I believe you said that's not what makes this work, right?
No.
And that it's the interactions, right? It's how they work as teams. Am I correct?
Yeah, it's an integrated system. Absolutely, it's and we used to say that. You said you're welcome to take pictures of all the artifacts. You can have copies of all our checklists. You can have all of it. It's not a secret. It's not a trade secret. But what you actually want, you need that. However that fits into your own environment, but you also need the people and the teamwork, the mindset and attitudes. That's what I can't take a photograph of. You have to see it and experience it.
How do you know you're getting better, and what kind of tools and techniques are you using to improve team performance?
Great question. I think it comes down to what you and I talked about. How we met when we were talking about OODA loops, right? So, but observe, orientate, decide to do something, act. The key for me is what happens after you act. How do you know the thing you did is actually working? Now, you can apply that to an individual patient level. You can apply that to an individual healthcare provider. How do I know the thing I'm doing is better or worse than it was before? And you can even do that if you for healthcare systems. So if we ask our team, our whole team of 20, 30 people to change their practice in a certain direction, how do I know that when they do that is resulting in an improvement to the system? And we do that with data. We do that with measurement and data and real-time feedback loops.
All right. So what are you measuring in your world right now?
As a team, we start with, in healthcare, we work backwards. It's a kind of Amazon concept. So if you came to us as a patient or a family member of yours came to us, we would say, well, what is our target? What are we trying to do? So if you're having surgery, from an anesthesia point of view, I would like you to survive your surgery. You must, number one. Now, that's a given. We've made such advances in the last 20 years. No one expects to die in the operating room. That's a very, very rare occurrence.
Same thing in aviation, right? In
right.
Aviation, right.
Yeah. So if that's not the bar anymore, what do you expect after your surgery? You want to wake up in a timely fashion. So time of recovery. You want to wake up comfortable, so we can look at what your pain score experience is. We want you to wake up so comfortable that the nurse doesn't have to administer you a narcotic, because that you have all these complications associated with that. So if you don't need a narcotic when you wake up, you want to wake up so comfortable you don't have any of the common side effects. The commonest side effect is feeling nauseous or vomiting. And then from a surgical point of view, you want to wake up comfortable, discharged safely, and you don't want to come back to the OR. You don't want to represent to the ED within 7 days, or come back for a second surgery within 30 days. Or you don't want a surgical site infection rate. So you have these. That's your target condition. Mm-hmm. So then, if that is your true north and that's your target condition, is everything you do, how you think about your team, how do you deliver care, is that meeting those 6 or 7 objectives? And so if you measure that and say, everything we do, can we measure those 6 or 7 things I just mentioned? And when we make a change to the system, which way do they move? Do they not move? Do they move down? Do they move up? So, that's what we measure at a system level.
What I like about those outcomes, those measurements, they're focused on your customer, your patient. They're not focused on, the number of personnel or the number of people trained in such and such or anything like that. Those are kind of important. Those are outputs, but you're talking about outcomes. And I think that's what AdaptX does, is really help people understand outcomes. Is that correct?
Sure, absolutely. So outcomes is one part of it. The other part is looking at the processes of care, right? So if you center your organization to measure those outcomes and drive towards those, now you can look at in AdaptX, you can also look at the processes feeding them. For example, so there's a huge drive to increase operating room efficiency, and we've made some huge strides. So in order to increase efficiency, there's certain things you probably don't want to do. You don't want to ask your surgeons to wield the scalpel faster. So that's kind of like sacred time. So the cut to close time, it will take you how long it takes you to do that bit. Look at the little bits, the bookends before and after that, right? So what are you doing before the knife goes in? What are you doing when the knife comes out? How can you, an OR minute is valued at $180, $200 a minute. It's a really expensive environment. How can you compress that time and do it safely while still achieving those 6 or 7 objectives? And that's what we're able to do. We're able to stratify the data, figure out who's doing it best. And we had a surgical team. So they looked at the little bit of time before surgery starts, after the patient arrives in the OR. And it was 13 minutes before the knife goes in. And during that time, it's work. They have to, position, prep, and drape, and do a timeout. There was 2 surgeons who were able to do that same work in 10 minutes out of a group of 8. And with our solution, they were able to identify those 2 surgeons as outliers. So they called it Moneyball for medicine. It's like, I found something that you're doing which is different. Yeah. And before we copy you, just make sure that your outcomes are the same. Your 2 outcomes are the same. What is it you do that's different? They were able to scale that across the team, save about 4 minutes per case, and they added 24 cases a month to their schedule because they could systematically harvest that time. So yes, we're looking at outcomes, but we're also looking at the care delivery system and what can we optimize? Where's the waste? What can you tighten up?
Yeah, it's a system that drives behaviors. Hey, I want to switch over to something more UDA-ish and maybe even mental health-ish. And this just struck me a few moments ago. So situational awareness inside, surgical team in your line of work. How do you know when people have lost the bubble? Can you see that in an operating room? Can you sense that? And if so, how do you help people recover from that lost situational awareness? Yeah,
so situational awareness, I think you need to be very, very deliberate about building team situational awareness. And it starts at 6:30 a.m. for us. Everyone, step one, everyone turns up to work on time. You can't you can't roll in 10 minutes late, right? The important thing is we have an early morning huddle, a morning briefing, so that everyone knows what's expected, what are the unusual conditions that we're expecting that day, any risks to patient safety, any risk to staff safety, any risk to operational efficiency. So those are specifically called out.
So are you looking at the external environment, like what the CDC is putting out as what's emerging around the world? Or
No. Just what is in our local environment. We have 26 patients to take care of today, and you run the list, and you go, well, if it's totally routine, you're not expecting any turbulence or at that speed bumps, that's okay. But if there's a couple of unusual things in there, you should call it out. If you know that at 7 a.m., you can probably sidestep that or come up with mitigation strategies to make that go smoother, whatever that might be. Now, in terms of, so that's team situational awareness. In terms of individual situational awareness, you boil it down to an individual. So now imagine the team is working, they're in the live operating room. How do you know when something's going wrong? It's almost a philosophical question, right? And we teach this all the time. And we teach our team members, if what you are seeing with your eyes, what you're hearing with your ears, what you're feeling, tactile sensor, the inputs coming to you, if what you're seeing is not matching with the internal expectation of what you're supposed to see, that should be setting off fire alarms in your head. So, I mean, take a simple example. So you've been to the OR with me. You've seen when we inject the white medicine, the propofol, that makes people unconscious, and it usually takes about 10 or 12 seconds. Well, if I inject a syringe of that, and 12 seconds later, the patient's still talking to me, I'm like, what? That the reality is not matching my internal expectation. Something's wrong. Is the IV disconnected? Is it the wrong drug? Like, something's wrong. So being able to have a crystal clear mental map of what should be happening is really important. If you program a pump, we've counted this. It's almost 45 key presses to program a pump to deliver a drug. Now you're doing that. How do you know if you've missed a keystroke? Like, you hit start and it starts flashing, it's delivering. How do you know if it's wrong? You have to be able to do, we call this the DIMS check. Does it make sense? We look at the number that comes up. Well, this is infusing at 45 mils an hour. Does that number make sense? 45 mils an hour, is that take a swag at it. Does that make sense for this size patient? So yes, you work, but always like, are the inputs I'm getting from my environment matching what I think it should be? Now, if you don't have an internal expectation, your ability to detect an error is very limited. You're now like flying in fog, right? And you're not going to know. You're not going to know you're going to fly into the side of a mountain until you almost crash.
So how do you develop?
You want to be able to.
Yeah. So how do you develop that awareness in others that don't have that experience?
So you build really strong teams with really, really robust clinical standard work. You have to have a standardized way of doing something. If it changes every single day, every single morning between cases, and you have all this variability between teams, nothing ever looks the same. If one person is running that checklist in an entirely different way from someone else, it's going to feel off, right? So how do you create robust systems that are repeatable and reliable?
Yeah, so this goes back to your this goes back to your Starbucks example too. It's not just the technical skills that need to be standard; it's your soft skills approaches too, right?
Absolutely.
Okay. Hey, let's go back to the 6:30 stand up, and let's talk about the bigger picture as far as mental health, stress, the fact of what's going on all around everybody today. So I think there's more than just having that trigger, that huddle, that morning stand up, if you will. In aviation, we had to get certain hours of sleep. You couldn't have alcohol in your system up to 12 hours prior. There's many factors that go into peak performance. And then I think, your world, you have to be at the top of your performance almost every day. I may be wrong on that, but that, as a customer, patient, I want a high performing team with some of the best people on it as possible working on me. Right. I don't think that's always true in healthcare. and a lot of it could be driven by the amount of stress that's going on in our lives. So can you talk us through what, improving an OODA loop or improving how you perform, how dependent that is on your sleep, your nutrition, and things like that?
Yeah, I think your performance is. How do I think about this? So I think about, our environment. I'm going to stay in the operating room, but, you could apply it to any acute healthcare area, whether it be the emergency room or the intensive care area, anywhere where it's, a VUCA environment. Your performance, your ability to multitask is based on your capacity bucket, right? And your capacity bucket is, just a theoretical construct of, how big is your bucket that allows you to do multiple tasks. That includes maintaining situational awareness, that includes team communication, that includes the technical tasks of your job. Your ability to do that capacity bucket goes smaller if you are sleep deprived, if you are stressed, if you are scared, if you are hungry, if you are cold. So it's about managing those resources, managing those elements as much as you can. So the things as an individual, it's your responsibility to come to work appropriately rested. You shouldn't be out drinking at 3 a.m. if you have to start a list at 6:30 a.m. That would be responsible. So there's certain individual responsibility. The organization has a responsibility that you can't make people work consecutive shifts. Like, I'm not allowed to work 2 consecutive weekends because that would be working like 5 days, and then 2 weekends you'd be working like 20 days straight or something crazy. So you can't do that. So in terms of like other things you can manage, fear. Now, fear is a good adaptive response if as long as it doesn't become maladaptive, right? So it's okay to be scared in an environment. It's going to be related to your experience and have you encountered this situation before. But we work in teams, and we see this in our trainees. You cannot make them fearful. As a trainer, I can't make them fearful of me. They cannot be intimidated. They cannot be fearful. There is obviously a hierarchy, just like in any other structure, but my job is to reduce that cockpit gradient, for want of a better word, right? So make it, we should be on first name terms. You should be able to talk to me. You should be able to question. You should be able to, without fear, you should be able to ask if you don't understand. And it's my job to create that environment. It's not the trainee's job to step up. It's actually my job to make it possible to have that conversation and create that learning environment.
Yeah, you and I talked about psychological safety when I was there, and the importance of displaying fallibility. As a leader, you got to be able to show, hey, yeah, I screwed up. I did this wrong. I think we talked about that then. That practice, is that hard to do?
Is it hard to do? You just have to have the will to do it. I don't think it is hard to do. We don't see it enough in healthcare, and it depends. There's geographical variation for sure. Even within a city, there's variation, and if you speak to folks and observe, you can see there's variability of how well that's applied. Psychological safety, that's a big topic dear to my heart. We're talking about your this construct. You have this kind of small circle, which is your comfort zone. You have this bigger circle, which is your anxiety, panic zone, where you're totally dysfunctional. And then in between your comfort zone and your panic zone, there's this thin edge, your growth zone, right? So right at the edge of your comfort zone. So when we're training, how do I keep you right on that edge? You are uncomfortable. That's okay, because you're learning. This is new. But how do I keep you just on the edge of your comfort zone, just in that growth area? Because that's your maximal growth area. If you're going to work with us for 10 or 12 hours a day, you want to be in that zone all the time, because that's where you're going to learn the most. That's where all the lessons are going to be imprinted. That's where you grow. And we can apply that. We can apply that now to our systems. I'm out of training. I've been practicing 25 years. I'm trying to find that growth zone all the time. Like, how can I improve my performance? Like, how can I do that better? And there's always better, right? And you're never done. If you look at the top sports people, you look at the best tennis people, or the best soccer people, they have a coach. And they are trying to improve their performance. Just because you won Wimbledon, it doesn't mean you stop training. You can still get better, right? So, and the way we do that, again, it's your OODA loop, right? You have to have the feedback. How did I do? For my last 5 cases that I did, how did I do? I was just looking at that yesterday. How have my last 50 cases compared to the 5,000 before? Am I still performing at the level I want to be performing at?
How does luck play into the outcomes? And this goes back to, we can do everything right in an operating room, or coming up with a product, or working with a customer, but sometimes luck just isn't in our favor. So how do you factor luck into?
I think luck is a randomizer, and there are things you can do to increase your luck surface area. So that things you can do to make you luckier, right? And you probably can talk to that as a pilot. Like as you flew more, you got luckier, right?
Yes, because you realize how stupid the things you're doing. Yes, exactly.
Yeah,
you're like, this is the dumbest idea ever. Yep.
Yeah, so you stop doing some behaviors, you do more of other behaviors, and that increases your luck surface area for the outcome you want. And I think it's the same thing. We talk, this concept of pure random luck, and yeah, sure, every now and then maybe, but actually, I think it's things you do on a system basis that increases your luck surface area, that makes your chance of achieving what you want to achieve, whether more likely, whether that is starting a small business, whether it's starting a tech company, whether it's improving healthcare systems. I think it's you just have to be systematic. And then if you think about luck surface area, think about a piece of paper. It's like it has 2 dimensions. What are the things that drive the y-axis? What are the things that drive the x-axis? Can you do more of those things to increase, what are the activities, the behaviors, the mindsets you need to do that? I think there's a systematic way of doing it.
What about the application of team training, team science, teamwork development with the administrators inside healthcare? Is that something that you're seeing an uptake in, or is there rejecting, a culture that, hey, that's not for us?
We are seeing it. It's taken a long time. I think when we started talking maybe 7 or 8 years ago, these concepts that were taught in team steps, simple communication concepts, S-bars, readbacks, they were almost, you think, wow, you have to teach people how to do this? And we spoke about this earlier. Like, these are highly trained, highly skilled adults, right. and they've gone to these highly paid positions, and yet you're teaching them how to formulate speech. Now, it's not just speech. You see it in emails, right? So, how many emails do you get a day? Like, I just cleared my inbox. I had 200 emails this morning. It was like, most delete. How do I cut through that chatter? How do I cut through that noise? We have to be trained how to use these communication tools effectively. And we're still developing. The latest one I've seen come out, so everyone's familiar with S-bar, everyone's familiar with readbacks now. Mm-hmm. Another one that's cropped up now is people have started starting their emails with BLUF, and it's like, what is
that's a military thing. Yeah,
right. It was actually from a military customer, and it's kind of like I've started seeing an uptick in that. It's like, bottom line up front. Okay,
I need you to do this. Here's a back. Yeah, and it actually follows BLUF with an S-bar sometimes. It's kind of cool.
And it's like, well, just give me the bullet, and I got it in 0.3 seconds. Okay, excellent, right? So, we do need these tools and strategies. And I think we have seen a slow uptick, but not enough.
Yeah, it's funny. I was working with NATO several years ago, and that's not the way NATO liked to write back then. That may have changed. They want to have a long write up and then the point at the bottom. I'm like, oh my gosh, I'm as an American, as a service member in the military here. Tell me what I need to know up front, and then I'll look for details as I need it. Right. Mm-hmm. So and it's amazing how these little tools and techniques can work out for any organization. I got a couple other strange questions for you. Let's see. So you learned a lot of this from aviation, pilot out of the UK. Mm-hmm. What do you read right now to learn from outside your environment? Outside of healthcare. What do you look to, or what are you inspired by when you read about training tools and techniques or anything outside of healthcare? Where are you looking?
These days, I'm the last couple of years, I've been very, very focused on data and how we can better leverage that. So a lot of it's still out of the academic journals. And really what we're trying to do, what we're seeing there now is more and more people writing about how are we using data. Like I'm less interested. I'm still interested in the big studies from the Mayo Clinic, sure, but I'm more interested in Hospital X from Oregon, and you just did this to your system. I'm interested. How did you do that? Like a kind of small scale, narrow focus. How did you improve X? Tell me that story. And those stories are coming out now. People are just beginning. It's like a digital revolution or data revolution. They're just beginning to really harness their data and go, wow, if I measure X, Y, and Z, that's the thing that I think matters. And I'm trying to drive to that outcome. And how did you do it? How did you communicate it? How did you enlist the team? What were the stumbling blocks? And people are being more and more open about, it's not this amazing success story. It's like I failed 3 times, but the 4th time I got it. And so this kind of it's a realm of research now called quality improvement research. How do you do real world quality improvement? And that's really, I think it's a really exciting era right now. There's this concept, I don't know if you've come across it, of digital aging. Have you come across this one? Yeah. So, now I can learn something about my healthcare system that it would have taken me 10 years of practicing within it as an individual, a decade's worth of experience. I can learn the same thing in 60 seconds now because I have access to the data. I can see outcomes across all my colleagues. So rather than having to figure this out over a 10-year period of doing it one day at a time, I can learn as fast as a Google search.
Yeah. Is there any danger in trying to measure too much from your perspective?
We're not in, I don't think we are, there's not a danger of measuring too much. I think that there is a danger of measuring the wrong thing.
Yeah.
And that's very real. So I'm a great believer in measure what matters and stop measuring the stuff that doesn't matter. Unfortunately, the world we live in has these historical tablets of stone, and they've always measured this. And one example from the operating room, for the last, 2 decades, people have been measuring a metric called FCOTS, first case on time starts. And what it was is and it's on the surface, it's saying, well, that makes sense. You're measuring, like, if you have an 8 o'clock start, what percentage of the time do you hit the mark at the 8 o'clock start? Right? It wasn't until I dived into it, then you realize, oh, well, that's a 20-year-old metric, and that's before we had electronics. And it was a retired charge nurse who told me 20 years ago, they made me run around the operating room at 8:05. And I just counted how many rooms had patients in. And if I had 10 rooms and 8 of them had patients, I have 80% FCOT. Great.
Yeah.
But the whole industry is driven by your FCOTs. Mm-hmm. Now, you think, well, what's wrong with that? And I would turn that around and say, imagine you were Delta Airlines, yep, and the only thing you measured was the percentage of time your first plane took off, yeah, as a marker of efficiency. Now, great, if the first plane took off, does that mean the second plane takes off on time, or the third? No. So that's one example of why measuring the wrong thing. You put too much emphasis on one metric. The other thing is the way you measure it can make you very, very insensitive to improvement. Let's stay with the FCOT example. Let's pretend that 50% of my rooms start on time. Okay, that's terrible. But the 50% that are late, they were 30 minutes late. So if you quantify it, right? Now, on time means you took off within, or you started the case within 5 minutes. So if you're in by 8:05, you win, right? But you're 30 minutes late. Imagine you poured a whole bunch of resource and everyone rejigged the whole workflow, and now you are only 7 minutes late. Mm-hmm. Well, that's a massive improvement. You went from starting 30 minutes late for half your rooms to starting 7 minutes late. You should be congratulating the team. But if you measure FCOT, you're still only 50% of your rooms made it. So because you put an arbitrary cutoff. If you don't, you either hit the mark or you don't hit the mark.
Yeah.
And if you measure, so it's just another example. Sometimes we measure the wrong thing or put too much emphasis on one metric. Sometimes we measure in a way that makes you insensitive to the team actually improving. And the corollary is true. It's insensitive to deterioration as well.
Yeah, so that's kind of the dispositional state of the system now. You got to look at where is it now, not the ideal future state. And you start with where you are now and improve from there, I think. If that kind of makes sense.
And create measurement systems that are sensitive to improvements. Yeah, exactly.
Yeah. No, these are great examples. And one of it's funny when you're telling the story about FCOTS, reminded me of my time in fighter aviation and an Air and Space Operations Center, where a general was having me track the number of times an aircraft would go flying, because that was a good measure to him in the logistics world. In the fighter aviation world, to us, it's how many effects can we put on the ground? How many bombs can we put on the ground? And that could mean one aircraft flying 20 times a day or two aircraft flying 10 times a day. So the metrics there, I'm like, it doesn't really matter. Look at the outcome we're trying to achieve, not the key performance indicator that you're used to. And speaking of key performance indicators, going back to when you and I were at the Museum of Flight and what we learned up at the Seattle Children's Hospital with the behavioral markers, to me, those seem to be a great way to get leading indicators on team performance, right? So is that what you saw with the use of marker systems inside of healthcare?
The uptick has been slower than I'd hoped for. We have, behavioral markers. We don't do enough of that work. We talked about this before. Like, there are concrete ways of assessing human factors, concrete, behaviors you do or you don't do. What I've seen, over the last 5 or 6 years, there has been a rollout. People have these safety tools, these behavior they're supposed to do. They're not assessed as rigorously as other things. So the things that are assessed are: did you wash your hands? Are you wearing eye protection? And again, because they're easy to measure, right? Are you wearing one mask correctly? Are you wearing the right shoes, right? So no one is saying, did you perform the timeout correctly? Did you give someone an opportunity to speak? Did you pause your work? No. And I think people are afraid to do it. That they, even though they now know what they're supposed to do, we haven't seen robust measurement of those soft skills and the behavioral markers.
And after you and I connected in Seattle, we worked on what we call Zone 5, so a behavioral marker system for team life cycles. And again, the reason the uptake isn't there, in my opinion, is in the industry I'm in, or the industries we coach, are because people often lead with the behavioral markers as saying that these are things you need to do. And from looking at them, their language is a little bit different, and they're mostly objective. But many people who aren't familiar with team steps or team development intervention or teamwork development intervention, they don't know what good looks like, right? So they just kind of use it on a scale. I'm over here. I'm a high performing team. I do these things. So I think there's a lot of opportunity in that space down the road. And a lot of that goes back to you looking at me and saying, hey man, we learned this from you guys. I'm like, oh yeah, we did do that. Right.
Yeah.
So,
I think it's a very ripe field and ready to have that conversation and ready for that work. We can improve our team performance so much more if we work on those non-technical skills. That's a term people use non-technical and soft skills as synonymously. To me, soft skills has this kind of connotation of it's soft, it's not that important. It's really important, and really the crux of making teams reliable, efficient, safe, consistent. Yeah.
But from your experience and what you're doing in your industry, it's working though. You're blending the data, looking at lean, human factors. It's working, right? These things are working.
Oh yeah, it's amazing when it does come together, and you put all of those components together. You put the systems-based practice together. You put the measurement systems in place. You have You have a group that is data driven, that actually looks at its outcomes on a daily, weekly basis, and then it's expecting to change their protocols. Like people now at the surgery center you visited, they expect 3 months later, like, what's our next tweak? They're expecting the next change.
Yeah.
And that is very, very different from most organizations. Number one, they don't work coherently as a group, so they don't pivot together when they change a protocol. People are doing their own thing, so they have this variability that's unmanaged. At the Bellevue Surgery Center, it's a very, very tightly coupled team. And so when we make a move, everyone moves together. And they are expecting to be in that growth zone. You know, it's uncomfortable to make change, but we've normalized, hey, every 3 to 4 months, we're going to make a tweak. And the tweak is going to make the system better. Well, we hope it's going to make it better. Well, no. We've made plenty of tweaks that didn't have the result intended. It didn't move the needle. So then, but at least you know, well, that doesn't improve, doesn't add value to your patient care. Well, let's do something else. And the one consistent thing is we will change. I do not expect to be practicing exactly the same way 12 months from now. That would be disappointing.
Yeah, there's no way out. And that's why we named this podcast this. You got to, we got these features of the world. The only way out is really to keep changing, change your orientation, improve.
Yeah. Love it. Yes. No way out. I'm going to totally adopt that.
Well, yeah, we'll give you the background on that. There's some pretty interesting things that John Boyd said about it and wrote up about the features of the world. Entropy being one of them, numerical imprecision, mutations. I wish I had the list in front of me, but that's there's just no way out of these realities of our world unless we learn how to change our orientation and improve performance. And I think that's what you're doing. So Doc, I want to, thank you for your time. This has been an awesome conversation. I'd love to have you back down the road, especially, maybe in 2024, as we look back to see how the world's changing. I think it's, every day it's crazy. It's very crazy out there, actually. And I also like to know, how can our listeners find you? And are you still taking executives through the hospital to show them what this looks like?
The hospital is beginning to open up post-COVID. So our continuous improvement team are beginning to start hosting groups coming back if they want to visit the surgery center and talk about these concepts in a bit more detail. You can find me. I'm pretty easy to find. I'm on LinkedIn, Daniel Low MD, you can get hold of me through you. And
AdaptX too, right?
And AdaptX.com. You can find our company on there. It's pretty easy. I'll be happy to engage with any of your listeners who are interested. Thank you.
And they don't have to come from the healthcare industry. They can come from any industry to look at it.
Not at all. Yeah, we're happy to engage in any conversations from interested parties.
Awesome. All right, Doc Lowe, I appreciate your time, and we'll connect down the road.
Yeah, please do. All right. Thank you so much. Take care.